We're also going to get things like a huge incentive. This might be not entirely that, but there's a big incentive for states to get out of Medicaid if the Senate bill passes. Because your citizens are better off in the federal exchange. And so states are going to look at Medicaid and run like for the hills, which is going to be interesting because everybody will end up in Obamacare. And we're also going to give up a tremendous amount of innovation here. One of the big problems is that we know that there are some reforms out there that are working. You've heard extensively about consumer-directed health plans. One of the things that hasn't been pointed out, and it's worth considering, is that they've been very effective with chronically ill patients in Medicaid. In fact, Colorado has one of the best pilot programs in the nation with its consumer-directed attendant support program, about 150 people in it. It's voluntary. They saved 20 to 30% back when they were running the pilot, and they let people keep 50% of the savings. These are people who, instead of having a Medicaid agency send them their home care attendant, got to hire their own. They know their health care, they know the best way, they know what kind of care they need, and they know the best way to arrange it. And if you give them 50% of the savings, they were happy to do it. And the better thing, the even better deal was that they got to buy things they needed, like lifts and voice-activated telephones that aren't covered by Medicaid. Everybody was better off. The state is whittling away at the program for who knows why. In other cash and counseling programs, same thing. Instead of giving people a regulatory burden, you give them a budget, and you say, we'll help you pay your attendants, we'll help you make these decisions, but they're yours. People save money. Same thing with the consumer-directed health plans like mine. I saved a bunch of money last year, even though the decisions were hard, because I didn't go for some imaging. So if you get the government and keep the government out, and we move towards these reforms like consumer-directed healthcare, and we move towards regulatory reform, and we move towards things like the Colorado Consumer-Directed Attendant Support Program, we can save a bundle. One of the reasons we save a bundle in consumer-directed care is it's all cash. I was speaking before a group of physicians, and one woman was terribly upset that she had to argue with an insurance company over a mammogram. But she was also terribly upset that I would talk about consumer-directed care. And my response is, well, if it's consumer-directed care and I'm paying cash, I will simply pay you for the mammogram. You don't talk to an insurance company. What is your problem with this? She just couldn't wrap her head around this. Maybe she has by now. You can always hope. So the more you can move to a cash economy in Medicare, like we have medical care, like we have in food and car repairs and everything else, homeowners, houses, the more you can move to a cash economy, the more you can reduce the paperwork, the more you can reduce the regulatory oversight, and the better kind of care bundling you will get. An example, and then I'll quit after one more slide, and that is when you go to the dentist. I had to get a tooth fixed. It's like, how much to cap my tooth? He says, I'm like, a lot of money, $1,000. Does it matter what kind of filling? Because I'm used to negotiating. No, because you're paying for my time, care, and attention. The materials cost are immaterial, really. I don't care what kind of filling or what kind of cap you go for. Here's your choice. That's called service bundling. Okay? You don't go to the dentist and get a listing for every little teeny-weeny thing he does, like you do when you go to the hospital and get a listing for an aspirin. And when you go to a private sector hospital, like they have in Britain, and you say, I need my hip replacement, they say, okay, our hip replacement charges range from here to here. You can go on the web and get their package prices. And they say, you have to come in, we'll examine you, we'll give you a firm price, it's good for 90 days, take it or leave it, we help you with the financing. That's the way a healthcare system works when it's mostly cash-based. There's none of this oversight business. Somebody might come in and see if there's any microbes in the hospital. Nobody has any problems with that, right? But they don't nitpick you about whether they used an extra Band-Aid or not. It really reduces paperwork costs. How much does it reduce these costs by? Oops, point at the projector. Press the right one. Oh, heck. Oops, I had it. It hates me. Can you go back one? I just want the table, the last one. That one, that's good. Yeah. Okay, thank you. So here's some cash prices. This is from a company, it's a Canadian company, Timely Medical Alternatives. Helps Canadians get cash care in the United States. He's now realized, hey, good business opportunity in the United States, people with high deductibles, people who just want fast care, people who want to save money. So now he's set up North American Surgery. He'll arrange surgery for you in the US for cash. These are the difference between the insurance contract prices, which are often set up with respect to the Medicaid price controls, and the prices that he will offer for cash. Now you're going to have to travel, it's sort of inside US medical tourism, but it's an example of the price differential that you get when you pay cash. And in fact, you can go on the web, there's a place in Oklahoma started by this anesthesiologist who had a vision, and it's called Oklahoma City Surgery Center. He's one of the people in this guy's clinics, and they have all their prices for basic ambulatory surgery stuff on the web, sitting there, and their little disclaimer says, these are our cash prices. We do take insurance cases, but it's going to cost you more. There you have it. So, any questions, I'd be happy. Thank you very much.